Okay. So I was going to start with one. I was going to ask a question on your behalf, and I was going to ask Dr. Chauhan. Well, because I think it's also really important, and NCAN has some podcasts on clinical trials, is that for patients to actually understand what the phases of clinical trials means. So when Aman goes up there and says, this is the most exciting thing that just came down the pike, and it's a phase 1, why don't you explain to the audience, Aman, what a phase 1 trial versus a lot of your phase 2 trials versus a phase 3 trial, what does that mean for a patient looking for treatment options?
Thank you, Dr. Maluccio. So that's a wonderful question, and I think I can dodge that bullet because I have a good reason. So our keynote speaker in the afternoon, Dr. Elise Cohn, will be talking and explaining all these terminologies and what are these trials and how do a patient pick between a phase 1 versus a phase 3 trial versus a placebo-controlled trial versus somebody who gets all the drugs, so open-label trial. All those nuances. So if we didn't have that talk coming up, I'd be very happy to engage. But great question, and I think I dodged my...
Yeah, what I wanted him to explain is that a phase 1 trial is not really looking at the effectiveness of that therapy in that diagnosis, but it's looking to make sure that it is safe to be used in patients with certain diagnoses. And since neuroendocrine patients can have particular issues, I think phase 1 trials are really, really important. But that at the end of the day, if someone is offering you a phase 1 versus a phase 2 means that there has to be some question of effectiveness. Meaning, are we trying to test whether or not this is going to be effective in your case? And so there's going to be a lot more, at least some preliminary data behind it, which he showed us. I'm not sure whether the mouse things were any more gory than Eric Liu's things, but he showed some neat preliminary data.
See, we medical oncologists always feel that we don't have cool pictures and our slides look very dull. So, I'm trying to catch up with Dr. Liu and Dr. White. They have all these procedures. So we'll start having more mouse pictures, right, Neena? Okay.
So I've got a good one. Why don't I send it to Dr. Wolin, or it could be any of the medical oncologists, is that I don't think, unless I missed those talks while I was trying to, bring a transplant talk out from, the earth. So effective treatments for bone mets. So did we talk about whether or not, I can understand symptomatic bone mets, but if someone has multi-level or some component of their disease is bone mets, how do we treat that? Dr. Wolin.
I just wanted to start by saying that all of the treatments that go through the body treat bone just like they treat liver, lung, or any other site. So if you're being treated with PRRT, everolimus, lanreotide, anything you could think of that goes through the bloodstream, goes through the body, treats bone like everything else. Bone has a few unique properties. One is that bones can hurt, bones can break, and those are serious things if they occur. And sometimes we use extra special therapies on bones just to either prevent or treat those kind of problems. So if somebody has a bone metastasis in a bone which supports the weight of the body, like in the top of the femur bone, the hip, or certain places in the spine, those are potentially very dangerous because if they break, they can cause a lot of trouble. And those patients should be seen by an orthopedic surgeon who's familiar with cancer issues, and a decision has to be made about whether those areas can specifically be treated with radiation therapy, whether they should be stabilized with a pin or something special. So be aware of that. The other thing is we have a few drugs that target bones to help strengthen them. One is called Exgiva, and another one is called Iridia, and another one is called Zometa. There are several drugs out there that can work on bones to strengthen them and help reduce the risk of fracture. The problem is that those treatments have side effects of their own, and one of the side effects is they can increase the risk of having non-healing sores in the mouth if you ever have a tooth extraction or an implant or major dental work of that type, and they can lead to a fracture of the femur due to injury of the bone. So even though you're helping the bone, it can also have some adverse side effects. So those drugs are used with care. But if the bones are at risk of breaking or hurting, or you have lots of bone metastases, they're often very valuable. They just have to be used with care, and do not have to be used in every single person who has little spots in the bone that show up on x-rays as little extra white areas. So I think that would be the most important thing to say.
The other thing I'll say is that I showed you a case where I did an ablation of the bone. So if you have oligometastatic disease, or if you have disease in these big bones where you're risking fracture, sometimes stabilization means open surgery, but sometimes stabilization can mean minimally invasive. So we could do a vertebral augmentation where we stick a needle in, we ablate, kill the tumor, and then put cement in there to stabilize it. He talked about a pin. Pins can be done by orthopedic surgeons in the operating room. Pins can also be done percutaneously by us with imaging guidance. So it's really good to have a good orthopedic surgeon that can assess, radiation oncologist that can say, okay, we'll irradiate. Orthopedic surgery says, well, I'll take this to the OR, but this piece of it I need IR to put a pin in. So working collaboratively, again, it's not just one-stop shop here. You have to think about what bone it is, as Dr. Wolin said, but there are minimally invasive options for patients that aren't surgical candidates, or surgery would probably not help.
Okay, and then since you have the thing on, there was one that was specific for the spine. Would you say that that answer also is good for the spine?
We very commonly will do, if you have bone mets, there are places in the bone that were not good in the back, and so sometimes we'll combine it with radiotherapy, so you'll get SBRT, and then we'll go on to either do an ablation plus the vertebral augmentation. It doesn't matter the order in which you get it, we can do both, but you can't do them concurrently. So we can't put cement in and then you get radiation at the same time, because what happens when they do their planning is they map for the vertebral height and what it looks like in, if it's compressed, their zones will be different. So you have to do one followed by the other. It has to be in sequential, it can't be in parallel. So you can get both at one time, but it makes a lot of sense to have some sort of stabilization of the vertebral bodies after you get radiation, because you can get a compression fracture, which would hurt a lot more than sometimes the tumor infiltration.
I would just like to add that these are wonderful tools that we have for palliation, not necessarily for systemic disease control, right? So like liver-directed therapy is a great tool to actually control the disease. So when we recommend radiation, focal radiation to certain areas, we are worried either the patient has a lot of pain or there is an impending fracture. So these are called palliative procedures. So I was very happy to see Dr. White's slide on that even the scapula, the shoulder can be RFA'd. So those tools really help us. But these are not necessary if anybody has spine mats or they are tiny asymptomatic. You don't necessarily have to get radiation. So just wanted to kind of have that distinction.
Okay, then I'm going to pull it back over here to Dr. Mohamed. So once again, on the whole bone thing, because it comes up all the time, I inherited a program where the second that someone had bone metastases, we are putting them on one of these infusional therapies. And so if you have a patient that has been rocking along, and then beforehand, the octreotide scan that we used to get never even picked up the bone, then all of a sudden we got these really, really newfangled PET scans, and it was just like, oh my God, how'd we ever make a decision in this disease without this PET scan? So when you have a patient, say, Dr. Mohamed, when you have a patient that is developing bone mets, when is it where you have met your threshold whereby you would put them on one of these agents?
So I think I usually evaluate my patient on the symptoms, and when they start developing symptoms, definitely this is the time that I'm going to refer the patient for that. I also want to mention that there's a lot of data now that we have for using PRRT in these patients. So there's two factors now that we can see the patient does not respond very well. If they have a lot of mesenteric disease, or if they have a bone lesion, they tend not to respond as well. So this is one of the factors that we usually also discuss in our tumor board. Does this patient really going to be benefit from PRRT or not? But usually if the patient is starting having symptomatic disease, this is the right time to refer your patients. Some of the patients will have the bone lesions and will be stable for a long time without any symptoms, and just watchful waiting for some of these patients. By starting some of the infusional agent for bone strength will be suitable from the beginning, but if I'm going to refer the patient for radiation or more extensive treatment, I refer that until the patient becomes symptomatic.
One thing I do want to add to the same point that Dr. Maluccio was pointing is that most of the data that is out there recommending use of the agents like Xgeva or Zometa. These are drugs that strengthen our bones, so bone strengtheners is how we call it, is derived from the aggressive cancers, the typical, adenocarcinomas, squamous cell carcinomas. They're extrapolated to the neuroendocrine tumor, like, if you have bone metastases. So not everybody who has a bone metastasis gets onto these drugs. So it's not that a slam dunk that if you have a bone met, you have to be on Xgeva or Zometa. That's not something we should do. It's because of the risk, right? Dr. Wolin just mentioned these drugs are not without side effects, and we tend to utilize it more in patients, unfortunately sometimes in secondary prophylaxis, which means that, they presented with a fracture or had a untoward event, and then we know that this patient is prone to do that. Or if they have, the location of these tumors is such that they're prone, weight-bearing areas of the body, but not. And then there's the question of how long you continue, because the course of the disease is very long, and once they start on these drugs, how long they continue is another question that I don't know if we know the answer to. So I actually want to pose this question to our panelists here: how long do they continue bisphosphonates once they start?
I don't think there's any really clear answer, but what we have learned from people treating other diseases with these drugs for long periods of time and running into complications is that the complication rate is reduced if you spread out the interval. So instead of the traditional every month administration, these drugs can be given, for example, every 3 months, and then you would have 4 administrations in a year. It still seems to work well and reduce the complication rate. So it's an art using them and deciding when to use them and when to stop. If somebody has metastatic disease that is staying where it is and it's bad enough in the bones that you need these drugs, they usually continue indefinitely. But if somebody's treated, for example, with PRRT and has an excellent response, and there's no bone pain and the metastases are regressing, it may not be necessary to continue. The other thing to remember is that they hang around in the body for a very, very long time, and these same drugs are used for treating postmenopausal osteoporosis with 1 injection a year, and you could make osteoporosis improve with just that little bit. So really one of the big problems is overuse of these drugs and getting into complications from going on years and years and years of having treatments, particularly every month.
Well, since you have the thing, can you this is a really easy one. You may or may not have said, what is the status of the phase 2 trial of lutetium-177 versus everolimus in lung? Didn't you
that trial is just opening nationally, and we do not have any data yet.
Okay, so it's opening. So that's a really easy answer. Okay, so then on to Dr. White. So there is a lot. So the use of liver-directed therapies requires you to have arterial access, and there was controversy in a lot of liver-directed therapies on how systemic therapies would influence the effectiveness or the ability to get that therapy into the tumor. So this question is, how does everolimus preclude later interventional radiology or decrease the chances of your embolization procedure working? Everolimus, the chemotherapy. Mm-hmm.
So I've treated patients both before and after everolimus. So we just want a break from chemotherapy, usually about 2 weeks before we'll treat, just so you can wash that drug out. Other drugs for other cancers, if they have an effect on the blood vessels, we really want to take a break from that for at least a month, but everolimus, usually it's about a 2-week break before we'll go on. The issue is if systemic therapy causes some underlying liver dysfunction, that can limit our ability to treat. So if your bilirubin goes up or your liver is starting to get into that, the hepatic reserve, your liver's not functioning as well, that can be a problem. But typically, post-everolimus, blood vessels are not the same. I mean, they're fine. We can get in and we can treat.
And if I were to add to that, because I don't see Lowell here, is that Lowell actually did an institution-specific protocol looking at Affinitor plus embolization and found that the response rate was almost synergistic. He's promised me that paper for I don't even know how long. So we don't know the answer to that, but I think that Dr. White pretty much reassured us that there's no downside to it, and Lowell's going to tell us that maybe there is an upside to it, or Amon's going to say that hasn't been published yet.
I can throw a little light on that since we are next door neighbors. So yeah, we have treated I think well over 60 or 70 patients now. Dr. Anthony came up with this concept. It's called EVRO-EMBO. So EVRO stands for everolimus, and EMBO is our embolization. And there is some preclinical data to support giving concurrent. That means when you are embolizing the tumor, you have high concentration of mTOR inhibitor in the blood, so that you are, when you're destroying the tumor, that you get the drug into the remaining cancers. And this data was actually published in a very high-impact journal in HCC models when they gave the everolimus and then they embolized the tumors. And then there is some retrospective data, I think, from the combination that it can be done. We do it under our institutional protocol, and I think Dr. Anthony had presented some interim data at one of the meetings last year. I'm also waiting the detailed paper, but it looks very promising. The next step for would be to do a randomized trial with just an embolization arm versus EVRO-EMBO and to really tease out the true benefit. But it seems with the appropriate patient selection that it is safe to continue everolimus, and the protocol is that you continue the Affinitor pill almost a day or two before the procedure. So you don't really give the break, and you start back everolimus as soon as the patient feels that the toxicity from the procedures are gone. That could be 2 days, that could be a week out. So it depends. Every patient would have a little bit of pain, a little bit of nausea, vomiting, other things. So as soon as they're fit and somewhat back to normal, we ask them to get back on Affinitor. Of course, I'm not telling you guys to do that. This is what we do under our research protocol.
So when you do it, a quick question, did you do the full dose, the 10 milligram? Because now there's a lot of data, almost 50% of this patient need to have a dose reduction, right? So do we do the full dose 10 milligram or you go with the 5 milligram?
Great question, and Affinitor is one of those drugs with a very large therapeutic window. So we have patients who are on 5 milligram every other day for a few years now, and also patients on 10 milligram every day. So in our protocol, we use patients whatever they were stable on. So if they needed just 7.5 once a day or 10 every other day, whatever was working for them, we try to keep, because that's what they were able to tolerate. So we have to really tailor Affinitor in NETs patient in general, and that's a big issue in community. Because a lot of time people get started on 10 of Affinitor, that's the FDA approved dose, and they crash and burn 2 weeks, a lot of enteritis, a lot of diarrhea, fatigue, and rashes and mouth ulcers, and they just give up on it. It's a very effective drug. You just have to be a little patient and work with your doctors in optimizing the dose. So many times I actually start 10 every other day and escalate after a week or two, see how patient's doing, and tell them, okay, you did fine, let's try once every day. So it's a good drug, but you really need to be patient in finding the right dose for individual patients.
Yeah, great. So I don't think that Dr. Mohamed's going to have the answer for this, but we'll give it to him anyway. When or what time frame after being diagnosed with NETs do patients start having heart problems or valve issues?
I don't have the crystal ball to answer this question, but every patient is different. I think if you definitely have functional neuroendocrine tumors, it's very important from day one just to follow this patient very carefully with the 5-HIAA and have cardiology on board as well and getting the echo from the beginning. But usually, again, I don't know exactly if we have any data to answer this question specifically. But see, some data showing, I think, if whenever you have more 5-HIAA uncontrolled, you are going to have rapid progression and onset of CHD sooner than someone have 5-HIAA is more controlled. So I think it depends. Many factors is playing a role. I don't know if anyone of the panel have any information about specific data.
No, I just wanted to say that carcinoid heart disease can develop and progress incredibly fast. And I've seen patients develop carcinoid heart disease with valve injury so severe they needed valve replacement surgery within 4 to 6 months. So it can really happen fast. I've seen people even have surgery with bioprosthetic valves and 6 months later have to have redo valve surgery, which could sometimes be done by interventional radiologists with a so-called valve-in-valve replacement, but that can happen rapidly. So I think that anybody who's diagnosed with carcinoid syndrome should right away have an echocardiogram, be screened for carcinoid heart disease, BNP and BNP, but most importantly, a really good echocardiogram. If there's questions, sometimes a cardiac MR, and get that information early. Measure 5-HIAA, serotonin, but most importantly 5-HIAA. Plasma 5-HIAA, if you can get that, is so much more user-friendly and can be done repetitively without patients going crazy. And get that information quickly. If the serotonin level is high, get it down with somatostatin analogs, add talotrestat as soon as you need to, and escalate as much as you can and start immediately treating the cancer to keep the serotonin from being too high for too long. And whether that first treatment should be a surgical site of reduction or an embolization of the liver, where the bulk of tumor very often is in particularly midgut carcinoids and pancreatic nets. But just take this very seriously because it can happen fast.
I would like to add, so I was a fellow under Dr. Wolin, and actually him and Lowell Anthony interviewed me for fellowship, and that was the reason why I went to Kentucky to get trained. And one of my first clinics with him is that's what he taught me, not to overlook risk of carcinoid heart disease. So, if you start seeing that swelling in the lower extremities, always think right side heart failure, which is carcinoid heart disease. Actually, don't even let it come to that point. So you got to have a baseline echo and monitor. But I have a question for Dr. Vijayvergia. So the role of surgical cytoreduction in syndrome management, because carcinoid heart disease primarily because of excessive serotonin output, right? So how do you, where do you put surgical intervention there? You are upfront? Are you worried about carcinoid crisis during the surgery? You like medical oncologists to kind of bring down through their medical interventions and then go for surgery? How do you, what would your advice be?
So, sorry, can everyone hear me? So for surgical planning, certainly the preoperative visit with the cardiologist and medical oncologist are mandatory. If the patient is a surgical candidate and resectable, and we know that debulking can also help with symptoms, many reasons to offer surgery, but first they may require intervention with their cardiologist or cardiothoracic surgeon before they can get to surgery. And so just like with receiving treatments further down the line, whether it's from oncologic standpoint, when we start talking about surgery, the patients absolutely need to be presented at a multidisciplinary tumor board, and in many cases where they already have valvular dysfunction, are having florid heart failure, they're going to need potentially valve replacement before they even get to surgery.
Yeah, I agree with that. The mystery is that someone can have an elevated serotonin level for a number of years and not manifest any of the valvular changes, and then some people can have much lower levels and have the valvular changes, and so it's really difficult to know. So I have recommended treatment in otherwise stable patients predominantly because I have not wanted to just watch a serotonin level that was elevated, and not that there's any cutoff, because I hate serotonin levels that are over 1,000. So I just say it's an arbitrary thing, but that I would try to prevent something instead of ultimately having to develop the heart disease. I think it just limits options for you. And then the discussion about the operating room, whether or not it be heart-related problems or carcinoid crisis in the operating room, can just be a very uncomfortable position to be in. And so we do the valves. If anyone has carcinoid heart disease and is kind of on a borderline, we do the valve before we would consider doing surgery.
And in the OR, not every patient with a carcinoid tumor has symptoms of carcinoid syndrome, but certainly for those patients that do have excessive 5-HIAA and carcinoid syndrome, we would treat them with an octreotide trip during surgery. Whether it works or not is debatable, but for a patient who I know has carcinoid syndrome, my preference is to have them on that, and that's something that we work with anesthesia during the case?
I think that's a very interesting question. A lot of patient has that anxiety. Why don't we open it to a broader panel? I'd like to get IR input as well, because many of our patients, carcinoid syndrome patients, have to go for a tooth extraction or a major surgery. So the question is about crisis. So I've heard your approach as you kind of err towards caution, do some infusion. Dr. Malucho, what about you, and Dr. White?
Dr. Malucho, can you explain to everyone what crisis is? I think a lot of people...
Oh, sure. So carcinoid crisis is the blood pressure fluctuations that will come when you get rapid release of neuroendocrine-related markers into your bloodstream. And the problem with that is that some of the techniques that anesthesiologists will use to alter those hemodynamics, blood pressure issues, do not work as well in carcinoid patients. Now, I will just debunk the thing, since I'm the only one here from New Orleans, is that the whole epinephrine thing is extraordinarily controversial. And so all of you who worry about going to the dentist and having local anesthesia with epinephrine and the lidocaine, that is perfectly safe. The issue with epinephrine is that if someone is in carcinoid crisis, say you get in a car accident, you could have low blood pressure because you have a femur fracture. But the issue is that same trauma can then induce your carcinoid syndrome, and then the poor EMS guy is using all this stuff in his thing, and you guys can have a paradoxical reaction to the use of epinephrine. But the fact is epinephrine is not even the go-to necessarily at EMS, nor would we ever not use an EpiPen in someone with a seafood allergy that just got it. It's just somewhat different. The issues is that the management of carcinoid crisis can be very difficult because you guys won't react the same way to the drugs that we use routinely. Now, octreotide drips and the controversy behind octreotide drips when using is that octreotide actually is not the only component of that protocol. We use a combination of things to block a lot of the different receptors. So we use a histamine a blocker like Benadryl, we use hydrocortisone, we use octreotide, and we use Zofran. So the protocol that was controversial was whether or not the octreotide mattered. And I would agree that even though I've seen as many people come out of crisis, seemingly just to bolus them with octreotide, or people will be in an emergency department with what they're assuming is septic shock. And I'm like, okay, well, it can absolutely be sepsis. It could be the worst urinary tract infection ever. But that if it's a patient with carcinoid syndrome, you have to treat that, or you're not going to get them out of their shock, and then they're going to wind up with a lot more organ dysfunction. So the protocols are really important, although I think that exactly how you use them and whether or not there's any one component that is the winner. But so did that answer the question about carcinoid crisis?
I completely agree with everything you've said. The preoperative planning definitely needs to include more than octreotide. Ron Pommier in Oregon has done so many studies on the particular value of intravenous octreotide, which we all do and think it's part of the regimen in general. But his patients that did not need it were also getting octreotide LAR already, and they had plenty of octreotide in their bodies. But in any case, the combination of high doses of steroids and ondansetron and octreotide and all the things, Dr. That you've been hearing about now for the discussion of carcinoid crisis all apply. I think that it's very important that probably the single most important thing in my experience has been that the anesthesiologist and the oncologist need to talk to each other before surgery. Because if the anesthesiologist is not prepared, you're in for big trouble. And especially if the surgery is not happening at a major center where you have an anesthesiologist who's working with a surgeon and does this type of operation all the time. They're not prepared at all. They don't have octreotide in the operating room. They don't have experience in using these other agents in the operating room. So you really need to plan it out, because you can go into shock and have no blood pressure detectable just from inducing the patient's anesthesia before you even start the operation. It's not just from palpating the liver. It can just be from starting the case. I've seen people go into shock just having a colonoscopy. It can happen from any procedure at all where you're having anesthesia. So just be sure that the anesthesiologist knows what he's doing, and if there's any question, the anesthesiologist can talk to the oncologist before to be prepared, because you really don't want an unprepared anesthesiologist who's never given anesthesia to a carcinoma carcinoid syndrome patient before to be the person that you're entrusting your life to, unless they're prepared for the situation.
And what I'll say is we don't use anesthesia routinely for patients with metastatic neuroendocrine that we're doing liver-directed therapy on, but I certainly have seen it on my table. And it typically happens when I get my catheter into the celiac artery, which is the artery that supplies the liver, and I inject contrast. I don't even have to touch the liver. The contrast goes there, and all of a sudden, patients say, I don't feel so good. And I look over, they're beet red, and their blood pressure's going crazy. They can either be high, they can be low, it can be anything. There can be bradycardic tachycardia, high heart rate, low heart rate. You don't know what you're going to get, but they turn beet red. And so at that moment in time, we give the protocol that we just talked about. So you're getting high-dose steroid, you're getting a Benadryl, you're getting everything on table. Sometimes we have to abort, and we say we're not going any further. Oftentimes, some people will say, oh, it's a contrast reaction. These are patients that have come and had CT scans in the past. It's not a contrast reaction. I've already injected contrast in the groin. So you have to just have an experienced interventionalist that knows, okay, how you feeling? And it doesn't have to be somebody that's been symptomatic in the past. And I've treated patients, over years. I had one patient that I treated many times, and she came in, and for whatever reason, that week, I treated 3 patients, and all of them, I was like, what is today? What are you putting in the water here today? But you can have it at any time during your course of therapy. So you just have to have somebody that knows how to deal with it. So on table, we get you off the table, or we give you the appropriate therapies. And most of the time, I've only had to abort one and say, I'm not comfortable continuing because I couldn't manage the blood pressure. But we can treat through and continue on. But you just have to know about it, expect it, and know how to manage it.
So it seems like you don't do it till like you don't do it ahead of time.
So prophylactically, we give short-acting sub-Q, and again, that's controversial, but we give a short-acting dose right before you get on my table, 200 mics.
Yeah, we do it in
Sandostatin.
everyone. Yeah, we absolutely give a pre-procedure thing. So we do the entire protocol prior to any surgical procedure, any IR procedure. If something's doing orthopedic under a regional, we don't, because you don't have the same, systemic effects. But what I say is it's better to try to keep the bees in the hive than try to get them back in the hive after, you just shot a bullet.
There's somebody raising their hand.
Yeah, what I can say is you're the best patient advocate. You're the best advocate for yourself. And I can tell you that I know. I know. Why don't doctors know? I know. I'm here. I get you. I get you. What you say to your surgeon who's performing the surgery is that you need to call anesthesia, because every patient that gets anesthesia with me, I've had a meeting with the anesthesiologist performing the procedure, not any anesthesiologist, right? Because you don't know who you're going to get that day. I want to know who it is, and I want it assigned to my case, because I need to know that this patient is going to be all right, and we have a good understanding of how we're going to manage the patient. So I would say, and I know, we should know, we should be better, but we're not, at 2 hospitals apparently. It is scary. But I would tell your surgeon, you need to have a conversation with the anesthesiologist performing the procedure that day. And then you want that anesthesiologist in the room during induction, right? Because that's when it happens. So I don't let the CRNA, which they're fantastic. I want both of them in the room at induction. I'm standing in there. but they have to be in there with me, and that's my expectation when I have patients with metastatic neuroendocrine that have had problems. Yeah. And it worked? And it worked? Yeah. Yeah. Well, I'm sorry that has to happen, but good for you for being an advocate for yourself. Yeah.
We do give you a copy of the protocol too. So if we're ever having trouble with patients that live in some of the rural parts of the southern region, they have a copy of the protocol that they go. Meaning you have the copy. I sure can. It's Bob limiting the question just to everybody. Yeah, so exactly. Or you can just find these people during lunch, because there actually are things that I think you could discuss over lunch. But one that is also, I think, something that people won't understand, so let's go with Aman again, is that we talk about how important clinical trials are in rare diagnoses. Sometimes the things that are coming down the pike are almost more promising than what it is we're offering. And so I think most, if not all, of these panels are very, very strong advocates for clinical trials. But this is kind of a slap you in the face question. So a lot of patients are not near major net centers, but nowadays we can see you all virtually and give advice, and that advice may include some of the upcoming clinical trials. But that they can't go, especially if you live in poor Louisiana, cannot go all the way up to Kentucky every 2 weeks for your trial, Aman. So are there any chance for clinical trial patients to be followed locally, making those clinical trials available to them?
Well, I might be moving to Miami, so not too far. So, no, I think you hit the nail right on the head, and that's a larger issue for medical oncology in general. We want most of our patients to have access to the best and the latest and the greatest. However, the current clinical trial participation, even at the best of the best centers, under 10%. Majority of patients are treated in the community, and NCI, FDA, industry, they realize that majority of care happens in community, and academic centers are just few and far, and we can't really do all the trials there. So the trials, at least the big registrational trials, are more moving towards community. For example, the NET retreat study, the randomized control study, is supposed to be able to be rolled out at any community center who is doing Lutathera, which there are about more than 200 of those. So these cooperative group studies are very easy to open in places, in most cancer centers where you are getting these standard care therapies. The tricky issue with phase 1s is the phase 1 studies are very, very intricate. These are sometimes first-in-human trials. They need very specialized set of group called phase 1 units. There is a lot more blood work, tissue work, pharmacokinetics. There's just too much. Each patient we see, there are at least 20 people behind me kind of managing a lot of different things, biobank, regulatory stuff, FDA reporting. You sneeze, we have to report. You know, a lot of time in the middle of the night, I'm signing these things and sending it to government. So all those are unfortunately the challenges, and I think the phase 1 would probably still be better off in those pockets which are equipped to do that, because the last thing we want is put patients under risk. But you're right, phase 2 and phase 3 should clearly be rolled out and democratized, and we should have, and I think there is a big push from the governing bodies towards that. But the point well taken. As of now, you know, I would encourage you guys to look at clinicaltrials.gov and look for all the locations that these trials accessible. Sometimes there might be a really interesting trial right in the next city available. So please don't feel disheartened if you think, oh, these are great trials, but you live very far off. I do hear you. We talked in some of our Zoom meetings with NCAN and other groups, you know, from international countries, and they feel even more restricted. So I hear your point, but we are constantly advocating for you guys, and hopefully this would be less of a problem in the near future.
And, you know, I think the COVID pandemic had some really bad effects, but some good effects it had in terms of teles. Now clinical trial management and development of trials is being pushed towards trying to accommodate patients coming from far away. So you know how you saw a lot of studies that are randomizing people, so half of the people get the experimental treatment, the other half are getting standard treatment. So for example, net retreat, you're getting Lutathera, but other half, one third of the people will get everolimus, which can be done locally and can be monitored by the local oncologists. We are still in the process of how this happens, but the next big step is standard of care treatments can be done locally, so that patients are not coming all the way for nothing. Just it's because of all the burden that it entails. But these are things that are trying to be done and worked up as we move on, but still not there yet.
And it
would
has
say
to do
it's-
with the regulatory requirements. And so clinical trials are highly regulatory for all the right reasons. And so it makes it very difficult because, say, for example, if you're the principal investigator on a trial, you are 100% responsible. Like, you may be in an orange jumpsuit if things go awry on a clinical trial. So it's heavily regulated, and therefore that's easier to do at a single site. But that's one of the reasons why the NET programs that are spread out across the United States, we get along really, really well. We just are trying, as Dr., and I'm going to just say Dr. Nam instead of trying that, is that we're trying to deal with it so that it is more democratized. And so therefore I would be leveraging for the people in the South, in order to at least have a site in the South. The South, we have unique challenges. We actually have a housing unit for people if they need to come into town, because we have so many people that cross state lines, but that we've also used philanthropic dollars to send people for clinical trials that we think are really appropriate for them. And so I think that all of us here, Wolin was talking about his philanthropic efforts, is that most of the neuroendocrine subspecialty centers are really truly advocates for you, and so it doesn't make it any less laborious that you would have to go there, but I think that there are a lot of avenues to get you to a clinical trial if it's the most appropriate for you.